Welcome everybody to this our little Zoom conference and discussion. I've spoken before to the nurse case managers. Many of the nurse case managers I've met throughout the years as they come into our practice, and they're such a huge asset. You know, I remember when I first came into town about 20 years ago, a lot of the senior partners, they didn't like it when the nurse manager, case managers were around, and they kind of left them in the, remember those days when they left them in the waiting room in the lobby, which I never really understood, because the nurse case managers are such a huge asset for the patients and for us, you know, because you have to walk that line being a patient advocate and at the same time, when there may be malingering personalities or something, kind of see through that, but still kind of maintain maintain your objectivity. So my hat goes off to the case managers. And again, I've known many of you for many years. My hat goes off to Karen. I've known Karen for 17, probably 20 years before she was here. She was at the Elliott and we had interactions back then. As I continue to tell her, she's probably the most vital asset that we have in our practice, and the workers' comp team we have is pretty incredible. In terms of myself, again, I've been practicing at New Hampshire Orthopedic Center for 20 years. When I first came here, I came from Hartford Hospital, where I did my training, and then after that, I was in Boston. I did a sports medicine fellowship with the Boston Celtics, so I came into town, joined Jim Vallis when we were over in Kosciuszko Street in Manchester. And at that point, you know, Dr. Vallis was kind of the sports guy in town. So what would happen is a lot of the workers' comp would come in, and I would see them because I was the new guy, and the workers' comp patients needed to be seen pretty quickly. So the injuries oftentimes are the same, right? Shoulder injuries, knee injuries. The difference is the athlete wants to get back to playing, and oftentimes the worker doesn't want to get back to work. But nonetheless, that's how I kind of got started in this business, and my practice has been pretty much shoulders and knees, and a lot of it has been taking care of workers' compensation patients throughout the years. About 3 or 4 years ago, I did start a separate business called Prime Consulting, and that basically is a business in which I see individuals in Concord Friday mornings, in which I do permanent impairment ratings and IMEs. And again, that kind of stemmed out of the fact that I've done so much workers' comp in the past. And again, there were a number of requests for IMEs, and since I started to do a fair amount of them, I kind of carved that out, and I do that separately now on Friday mornings in Concord as Prime Consulting. Which brings us to this topic, IMEs. So I'm decided to present this topic, IMEs, because it's something that as case managers, you guys see these a lot. You see, you know, patients who have gone off for second opinions, third opinions, and the adjuster isn't certain which direction this is going in. So they go forward and schedule an IME, which is an independent medical evaluation. And an IME is usually performed by a physician, and that physician that performs the IME is not making a doctor-patient relationship with that individual. So we don't even, so when I perform an IME, I won't even refer anytime or anywhere to the individual that I'm seeing as a patient. They're really not a patient. It's more of a client. And I do not offer medical advice. I do not form a doctor-patient relationship. And really, all the opinions that I render are based on review of the medical record and the evaluation that is performed. So, you know, one question, so who asks for an IME, who requests an IME? For the most part, you know, a workers' compensation carrier, probably initiated by an adjuster, will ask for an IME. And again, it's an independent medical evaluation. I'll also see IMEs that are requested by attorneys. Occasionally there'll be a motor vehicle accident, and I'll be asked to perform an IME on behalf of plaintiff or the defendant. So in general, that's the basic idea in terms of what an independent medical evaluation is. It's just that it's an independent evaluation done by somebody, hopefully in that specialty, who has not made a doctor-patient relationship with the individual. And usually the IME will ask a series of questions of the examiner, which would be me in this case. And again, my answers are based on a review of the medical record, which sometimes could be, this high, and sometimes it could be this big. It really depends on the situation, and it depends on how long the patient has been seen by whomever. So that's the basic idea of what a independent medical evaluation is. Again, some individuals that perform these are, doctors who have kind of retired from clinical medicine, and they're doing this in the eve of their retirement. Nowadays, I think there are more individuals like myself that kind of do this as practicing physicians, but do this on a part-time basis as well. I will always tell the individuals that I evaluate, the first thing, again, because they're coming in to see me, and they're very skeptical because they were usually sent here. They usually received a registered letter in the mail, and it doesn't really tell them what this is all about. So they show up entirely uneducated most times what they're here for. So they show up, and sometimes they'll show up with a family member. And if they do, I just have them fill out kind of like a waiver just to say that they're there. I'll always perform independent medical evaluations with an assistant. I'll never be there alone, just for a number of reasons that you could certainly imagine. But again, lots of these individuals, they get a registered letter and it says show up, and they show up. And the first thing that I'll say is, look, you know what? My name is Dr. Gumas. I have a clinical practice. I practice in Bedford. I do this half a day a week. I do not work for the insurance company. And, I'm basically asked to review your chart and to examine you and to come up with some answers to some questions that whoever requested this is asking me. But I always kind of make it clear that, I don't work for the insurance company. I think it's really important to kind of get that message to the individuals that I see, because again, I could tell you 99% of the time they show up to see me and they really don't know what they're here for. And they're very skeptical because they think that I'm the insurance company doctor. So, nonetheless, that's my introduction to the IME and what it is. What I'm going to do next is kind of go through a lot of the different questions that are asked of me when I perform an IME. Okay, so common questions, and we're going to advance. We'll put the first slide. Common questions that come up. So causality. So what is causality? So when performing an IME, probably the number one question that is asked is, did the accident or incident that occurred on such or such date, did that result in the individual's current condition? Okay, so typical example, I'll see an individual who comes in, he works in the construction site, he fell, he landed with an outstretched arm when he was, slipped on some ice, had pain in his shoulder. The pain didn't get better. He reported to his boss. He was sent to convenient MD or sent to an urgent care center the same day or the next day, was evaluated there, was usually seen there. So nowadays, a lot of the urgent care centers and convenient MD, Express MD, which unlike the past, this is just kind of an aside, they'll actually hold on to these individuals a little bit rather than sending to a primary care. So classic stories, an individual falls, outstretched arm, they show up at convenient MD, they're seen once, some x-rays are taken, some physical therapy is started, they're seen a few more times, the individual doesn't get any better, and then what will happen is usually they'll be referred either to an occupational health center, or they will be referred directly to us, orthopedics. I'm not certain if sometimes that's probably dictated by the workers' comp carrier or the adjuster versus convenient MD. Or I use convenient MD as an example because they're so pervasive throughout our catchment area. So nonetheless, this will all happen, and then eventually this individual will end up at the orthopedics office, and I'll review the chart of all the notes. And causality, so we really need to, it's like forensics, we need to see, hey, does it make, let's say the individual has an MRI study of the shoulder, and the MRI study shows that there's a rotator cuff tear. Now, the question is that rotator cuff tear, that it just happened, or has that rotator cuff tear been there for 10 years? So you do a little bit more forensic work and you look through the medical record, because again, when performing an IME, I'll usually get records back to whenever, and we'll see, is there ever any incidents of a shoulder problem before? Is there ever any incidents of previous x-rays, previous MRIs? Is there anything in the past medical history to indicate that this gentleman who fell and injured his shoulder had a previous shoulder condition? Okay, so assuming, let's say that he had so Mr. Smith had a shoulder condition 5 years ago. He was seen, an MRI wasn't done, he was treated with therapy, and now this other incident occurred. They do an MRI study. So, and this is a case that what I'm repeating actually is a case that I just did an IME on a few weeks ago. So they do an MRI study, and the MRI shows that he has a large rotator cuff tear, okay? So large rotator cuff tear, but it also shows that there is some atrophy of the rotator cuff, which a lot of times when there's atrophy, it means that the tear may have been there for a while and the muscle shrinks up a little bit. So there's some atrophy on the MRI. The gentleman goes on and ends up having surgery. Okay, so surgery is done, and the surgeon is able to fix the rotator cuff. So, if this is the socket and then this is the ball, okay, this is the example I use for my patients. This is the socket, this is the ball. The rotator cuff attaches over here, okay? When the rotator cuff pulls off, it can be over here. So MRI shows that the rotator cuff is over here. So the question is, did this happen a long time ago, and now this is an aggravation, or, did this happen a long time ago and he's been living with discomfort but just didn't tell anybody? So we really have to do kind of forensics to look into causality and kind of come up with a determination. So this case that I'm telling you right now is an actual case that, as I mentioned, I did an IME on a few weeks ago. And this gentleman, again, he fell, construction site, outstretched arm, had a remote history of shoulder problems about 5-6 years ago. He's been working full duty, no issues. He gets this MRI recently, and it shows some atrophy of the rotator cuff, and it shows a large tear. So the question is, did he have this all along, or did this incident cause it? So again, when I'm reviewing this case, I'm still kind of up in the air. I'm not certain where it's going actually, but then he has surgery, and the surgeon, at the time of surgery, the surgeon is able to get a complete repair of the rotator cuff. So socket's like this and the ball is like this. The rotator cuff on the MRI is over here, but now the surgeon is able to reattach the whole thing. And what that tells me, if it was an old tear that was back here, and there was some atrophy, and then there was some significant retraction, technically as a surgeon, I wouldn't be able to get this and bring it back over and reattach it, but the surgeon was able to do that. So in my opinion, although there's some atrophy on the MRI, though there's a question of previous shoulder injury, the surgeon was able to fix this thing. And that tells me that more likely than not, this is more of an acute instance, or an acute injury that occurred, or what we would call acute on chronic. So maybe he had some chronic partial tearing, and then all of a sudden this incident happened and he tore the whole thing. But the fact that the surgeon was able to repair it and reattach it, tells me that that the condition, the rotator cuff tear, is causally related to the incident that occurred. Okay, so that's what causality is, and that's probably the number one question that is asked all the time. As a practicing surgeon, same thing happens to me. I'll see a patient. As a practicing surgeon, the patient will have a shoulder injury or a knee injury, and the question is, did this injury result in the current condition? And oftentimes, my patients will be sent to somebody else for an independent medical evaluation to kind of figure the same thing out. So it's really like forensics. I find it interesting. I think that there's a few key take-home messages I think to really think about. The biggest thing is mechanism of injury. So like, how did it happen? And there's certain mechanisms of injury that are consistent with certain conditions, right? So if somebody comes in and they landed directly on their shoulder, like boom, direct blow, the arm wasn't outstretched, they weren't falling out of their truck, they didn't reach up here, but they fell directly on their shoulder, that mechanism of injury is really not consistent with one that would cause a rotator cuff tear. Unlike falling on an outstretched arm, or you're falling out of your truck and you reach up and you feel a tearing or a pulling sensation. So the forensics and looking at the mechanism of injury, very, very important. Same thing can be, the same thing goes for any body part. So for a knee, for example, I mean, the classic example would be if you fall directly on your knee and you fall on your kneecap, call that kind of a dashboard type injury. Based on individuals, that would be in car accidents when the knees hit the dashboard. Very similarly, you're at work and you land directly on your knee and you have a lot of pain and it hurts and you can't get around and all of your pain is around your patella. It's all around your kneecap. And at one point, it could be a health doctor, or it could be convenient MD, it could be an orthopedic surgeon someplace. At one point, somebody will get an MRI. And I'll look at so I'll be doing my IME on the individual with patellofemoral pain, a mechanism of injury of falling on their kneecaps, and the MRI will show a meniscus tear. Okay. Now, clinically, if you look through the record, it doesn't show that patient has medial or lateral joint line tenderness, which would be indicative of a meniscus tear. Most of their pain is around the patella. Okay. Clinically, when I see them during an IME, their pain is not around the medial lateral joint line, which would be indicative of meniscus. Their pain is around their patella, right? So you have an MRI that's showing a meniscus tear, you have a mechanism of injury that's not consistent with that, and you have an examination that's not consistent with that. So although the MRI in this hand says, hey, meniscus tear, in that case, I would say there's no causal relationship between the accident that occurred and the current condition of the knee, okay? So that's causality, example of a shoulder, example of a knee. I'm gonna stop this section to see if anybody has any specific questions in regards of causality.
I do have a question here. Based on the skills required to perform IMEs and being forensic and looking at an IME case, how does this influence your day-to-day practice with your own patients, or perhaps with your own more challenging patients that may then be chosen to need to be referred to an outside IME?
That's a great question. I think that, so performing IMEs, and for the past, I think I've been doing IMEs through Prime Consulting for about 3 years. It has made me a much better clinician in the terms of documentation. So if I see an individual in my practice and and they hurt their shoulder, I'm going to be certain to document mechanism of injury, MRI studies, anything that would point to whether it's acute or not acute. So, reviewing medical records and looking at and doing IMEs and kind of looking through and I'm asking myself questions. How did so and so injure their shoulder? How did so and so injure their knee? And if it's not really documented, it's difficult for me to say yes or no. So as a clinician, I'm much more careful to specifically document my findings and kind of correlate, if they exist, right? Correlate MRI findings with clinical findings.
Great. Do you ever look at your client's job description before you're doing their IME?
The answer is yes. If that's a good question as well. And again, one of the other topics that we're gonna talk about is return to work issues. The answer is yes. I will tell you, just recently, just last night, I was reviewing a video of a worksite evaluation that was done by Sue Emerson, which many of you know, as a job site, as an occupational therapist, job site evaluator. So I was asked to conclude whether or not a woman had injured her wrist from her job, the specific duties that she did, making windows at a window factory. So for me to kind of really get a handle on what she was doing to see if it made sense, I did review a video of the work that she was doing. And again, so this can go both ways. So this can, like, look at a job evaluation of what they were doing before, but also a job evaluation of what they're supposed to be doing now. So that's a good question. I think that we probably don't do that enough, and probably don't pay enough attention to that. But oftentimes we're not given that information, at least clinically in my clinical practice. Phyllis Walker, who's with us, and Karen Mackey, oftentimes will go the extra mile to ask the adjuster or to ask the case manager to certainly provide that job description, because that is very important.
Great. I don't have any other questions right now.
Okay, we'll go to the next section. So pre-existing conditions, this is just what it sounds like. And pre-existing conditions can be pre-existing orthopedic conditions, or it could be pre-existing kind of comorbid factors that may contribute in how somebody is doing following an injury or following surgery. So I alluded before, I'll use the shoulder example. Like the individual that I referred to in a recent IME that I did, an individual that fell on the work site, outstretched arm. When you looked through the medical record, he certainly did have a pre-existing history of a shoulder problem. Oftentimes the extent of the condition, it can be tough to determine if we don't have all the medical records going back to whenever. I mean, one of the, doing independent medical evaluations, I'll get medical records to review. Most of the time, I won't have the records that go back 5 years ago when so-and-so fell and had a shoulder problem. But again, pre-existing conditions, whether it be a pre-existing rotator cuff tear, a pre-existing ACL or knee injury, important to know. Putting this into context, one of the most common kind of, no, not controversial, but one of those common IME cases that I see as a clinician, and also that I see as performing IMEs, is the individual that has an arthritic knee. Okay, so the individual has an arthritic knee. I had a guy who worked for the town of Manchester, and he jumped off of his riding mower, twisted his knee, comes in to see me, I look at him, get some x-rays, and he has an arthritic knee. Okay, his bone-on-bone arthritis. And when you look, review the medical record and you talk to him, he's never had any knee pain whatsoever. So really the question is, now we treat him conservatively, we do injections, steroids, and viscosupplementation and physical therapy, and everything we have in the bag of tricks. Conservative treatment. 4 months later, his knee still hurts, and now he needs a total knee replacement. Well, is it going to be compensated by workers' compensation, or is it not? And that's always the 50-50 question. My friends of mine who are attorneys, I've had this conversation with. So the bottom line is, if there was some event or an incident that resulted in the aggravation or acceleration of a pre, non-symptomatic knee, then the argument could be made that, this is a compensable with workers' compensation, versus is his current condition a result of the, of the general progress of an arthritic knee, throughout the year. So this is a case in which the pre-existing condition of an arthritic knee is really, it really becomes a bit problematic in terms of, is it going to be compensable or not? And it's tough. And I think that in most cases, if the individual has been entirely asymptomatic and they injure themselves, for the most part, it does end up being compensable with workers' comp. And this whole scenario with pre-existing conditions can go on for a number of different cases, but that's just an example. Apart from the orthopedic pre-existing conditions, there's also the pre-existing comorbid conditions, diabetes, rheumatoid arthritis, other anxiety, depression. So there's lots of conditions that one can have that can play a role in terms of how they end up doing after injury or after surgery. So there's been much in the literature that states that if you have anxiety and depression, and if you get injured and you have surgery, you're not going to do as well if you didn't have those conditions. So that's just, again, something that I will observe and look at and note whenever I'm doing independent medical evaluation on somebody. So not just the pre-existing orthopedic conditions, but pre-existing medical conditions. So any questions on pre-existing conditions?
I don't have any questions right now.
Okay, we'll do the next. So the Nexus treatment plan. And again, as case managers, this is your wheelhouse, right? Treatment plan. And again, I want to thank all the case managers that work so closely with us at New Hampshire Orthopedic Center, because I'm telling you, your help is invaluable. It really is, and I really say that sincerely, because whenever we do have a case manager that's with us at the time of the evaluation, it makes everything go much more smoothly in terms of communication. So, the question that I'm often asked with an IME is treatment plan. Has the treatment been reasonable? Has the treatment been appropriate? Has the treatment been causally related to the injury that occurred? Sometimes, you'll look at a case, it could be a back injury or a hip injury, let's say, that somebody has, and it's treated by comp and some type of treatment is done, but then suddenly, the individual develops back pain, and you see that they might be on 5 medications for their back, which might kind of be a separate issue. Next thing, they're going for a spinal stimulator for their back, and then I'm asked the question, do I find the treatment plan is reasonable, necessary, and causally related to the injury that occurred? And you really kind of have to sift through that, and you have to kind of apportion, because sure, they had this hip issue, and they were treated with a cortisone shot in the hip, and that was all secondary to workers' comp. But then the individuals say, well, they started to overcompensate, then the back started to bother them, and then they went down that pathway. They went to the pain clinic, and they went to the physiatrist. Then now they have X-rays that show an arthritic back, and they're getting facet injections and a spinal stimulator. So is that treatment plan, is it reasonable and causally related to the original injury? Now, the treatment plan might be reasonable. I mean, if they're getting a spinal stimulator for this bad back that they've had, it might be reasonable, but is it really causally related to the accident that occurred? And that's, again, that's something where it kind of comes into forensics, and it really requires kind of looking closely through the medical record and doing your evaluation to really see if that treatment, not only if it's appropriate, but again, when you're doing the IME, it's always not, sure, it's appropriate, it sounds great, but is it related? Is it related to the original injury that occurred? And that's a question, again, with pretty much every IME that I perform. And it's always a question about the treatment plan. So, any questions on treatment plan?
I do have one question. Is chiropractic ever part of a treatment plan?
So that's a good question, and I would say yes. I would say yes based on, there's a few studies a while ago, I can't quote the author, but there are a few studies that looked at chiropractic treatment for low back pain versus physical therapy for low back pain. And actually chiropractic treatment based on a few of these studies was just as efficacious or better than physical therapy for the treatment of low back pain. So, but again, where this gets kind of tricky, right, is, the individuals will go off to the chiropractor and they'll be seen for like 1,000 visits, and they kind of gets lost. So again, I think that judicious use of chiropractic care, I do that even in my own practice. I mean, I don't see a lot of patients with back pain. I will see some individuals as a shoulder surgeon who have kind of crossover neck stuff going on. And I think for the right individuals, chiropractic, care is valid. It always gets so that then you could take that a step further. Massage therapy. Bunch of patients who got a sore neck and they want workers' comp to pay for massage therapy. Not so sure. I mean, I'm certain that makes them feel better, but is it really, is it really appropriate? And I would be less likely to say yes versus chiropractic care, but that's just my own personal opinion.
Great. I don't have any other questions right now.
Okay. So maximum medical improvement, also known as MMI. Okay. And again, I deal with this in my own clinical practice because I see lots of workers' compensation patients, and I also I am also making this determination when doing most of my IME work. So maximum medical improvement basically, it basically asks the question, okay, Mr. Smith got injured, okay, Mr. Smith may have had surgery or maybe he didn't have surgery, but there becomes a point in time where Mr. Smith is no better and no worse. Mr. Smith has plateaued. And, when I first started practicing and doing this stuff, people used to always throw around 1 year. So it takes 1 year before maximum medical improvement, which is really ridiculous because it really depends on the condition, okay? So you come in the office and I see you and you have a meniscus tear, and I take you to the OR, I do a partial medial meniscectomy, and you go to physical therapy for 2 weeks. After 2 weeks, I get you back to light duty work, okay? So now you're working light duty, and you're doing that for maybe 4 weeks or 5 weeks, and we advance you. And then 3 months later, after your meniscus, partial meniscectomy, you're pretty much all better, okay? So 3 months after a partial medial meniscectomy in this individual, they're at maximum medical improvement. They're no better, they're worse. Maybe a little soreness, a little achiness, but they plateau, okay? So that's maximum medical improvement. Now, shoulders, a little different, total knee replacement, a little different. So if you have a rotator cuff repair and you have surgery and you're in a sling for 4 weeks and you start therapy after a few weeks, and then I usually don't start strengthening after a rotator cuff until 3 months because it takes 3 months for the rotator cuff, the tendon, we tie it down to heal, okay? So 3 months, now we're doing some strengthening, okay? If it's a manual laborer, he might not be at maximum medical improvement until 8 months to a year if he has to lift 100 pounds. So we really need, because we really need to maximize what he can do versus maybe an office worker who might be at maximum medical improvement a little bit earlier. So it used to be 1 year. So I don't, maybe tough shoulder, 1 year, small rotator cuff, 6 months. But the bottom line is it's a little bit different for each individual. But what it really means is, when has this individual plateaued? When are they no better? When are they no worse? When have they reached kind of their steady state? And that's what we call maximum medical. Any questions?
I don't have any questions on this. No.
Okay. So permanent impairment. So when somebody has reached maximum medical improvement, then they, in most cases, would have a permanent impairment. And the way that I explain this to my IME clients is that, look, before you had this injury at work, you were over here. Let's say that you were 100%, okay? And then something happened over here. You were injured, you had surgery, and then now you kind of re-equilibrated. So now you're like over here. You're not what you used to be. You're pretty good, but you're not what you used to be. You're over here, okay? And as a result of what happened between here and here, there is some permanent impairment. So you have some percentage of you is different than what it was before your injury. And I tell them there's a book. There's the green book called The Guides to Evaluation of Permanent Impairment, the AMA. We use the 5th edition. And every condition is in there. So the most concrete thing that I explain to individuals is, let's say that you had an amputation. You amputated your index finger at the knuckle. I look in the book, index finger amputation at knuckle, 10%, okay? Let's say that you injured your shoulder. So for me to assess how you are different than you used to be, there are 6 different ranges of motion that I look at. I look in the book, and it gives me a percentage, okay? There are other things that are based on what was done. So if you have a meniscus and they remove part of your meniscus, you're going to get 2%. If you get a meniscus and they remove the inside and the outside, the medial and lateral part of that, it's going to be something else. So, and again, when you look at the guidebook, the evaluation book of permanent impairment, sometimes there could be 2 or 3 ways that you can assess something. So, for example, I had an individual who I did a permanent impairment rating on, and he had an injury. He fell on his left side. He injured his knee. He had a tibial plateau fracture. He had surgery on his knee. He also had a hip problem. He had a hip surgery as well. So when you look, so I looked under the knee, and you could look in the green book, and it says, okay, it goes, it's a tibial plateau fracture with 5 to 7 degrees of displacement, results in 5% whole person impairment. And then you look at the hip, and I look at the range of motion of the hip, and that's diminished, and that ends up maybe 10%. So when you look at the knee and the hip, you can combine these together. And there's another chart when you combine things. It's not really, if you add them together, then you subtract a little bit. But anyway, but my point is, let's say that based on his knee injury and his hip injury, I look in the book, and as a result of the diagnosis of the fracture, it gives him one thing. The decreased range of motion of the hip, it gives us something else. And that totals 15 degrees, okay? But if I also look, the guy also walks in with a cane. So you could look in the book, and they could say, if the individual relies on an assistive device, which this guy did, then it gives you 20%. So what you're supposed to do in cases like that is you're supposed to use the largest impairment. And there's certain things you can and can't combine. So you can't combine the fractured knee with the hip. You can't combine that and the cane, because the cane kind of takes care of it. So, but my point is that there are different criteria that you can utilize to determine an impairment in an individual. And there's kind of rules that you have to follow in terms of what can be combined and what can't be combined. But no matter what, you're supposed to use whichever methodology you use is supposed to be the one that gives you the highest impairment rating, okay? So that's permanent impairment. Any questions?
I do have one. Is there ever any subjectivity or wiggle room when deciding PIR?
The answer to that would be yes, and it's unavoidable. So I'll give you an example. There's certain methodologies that you should avoid. And so you should avoid muscle testing, right? So again, you should look at every other possible way to come up with an impairment methodology instead of muscle testing. Because again, if you're asking somebody, okay, let me see how strong you are with supinating or pronating your wrist or flexing, they could just not give the effort. So you should try to avoid that. And most of the times you can't avoid that. I can tell you very, very rarely will I ever kind of use that. Sometimes you're kind of forced to use it, but very rarely. I do a lot of shoulder impairment ratings, and the answer is yeah. I mean, so active range of motion will have the patient lift their arm up, and they could certainly limit how much they're moving their arm with forward flexion or in abduction. So yes, there is some wiggle room with that, but it's somewhat unavoidable. The impairments that are based on diagnostic criteria, meniscus tear, fracture stuff, it pretty much is what it is. But yes, there is some subjectivity. Now, one of the things I'll do, it's interesting, a lot of individuals that come for a permanent impairment rating, I would say at least half of them don't even know. They don't know why they're even coming to see me. So I'll just do an assessment. I won't say to them, look, you know what, you're here for your shoulder impairment, and let me look at that range of motion. I won't even say that. I'll just start looking at them, and I'll have my assistant on the side, and I'll just say, I'm just going to see a few things. Hey, lift that arm up. How far can you lift it up? So I'll actually take ranges of motion with them not really even knowing why I'm doing it. And that's probably about half the time. Sometimes they know why they're here. Because again, with permanent impairments, oftentimes they'll be sent by attorneys that represent those individuals who are kind of trying to solve their case. So they are kind of coached a little bit, and I kind of keep that in mind. But yes, the answer to the question is there's some subjectivity when performing permanent impairment ratings. The answer would be yes. Try to understand it and try to mitigate it, but sometimes it's unavoidable.
And one other question, is pain ever part of permanent impairment?
No, absolutely not. And I'll say that to patients, because not patients, clients, right? Because they'll come in and they'll say, they'll just start talking, this is freaking killing me. And oh my God, I can't do, that's like, fine. I'm just look at them. I'm like, that's great. But it really, it doesn't mean, and I explain to them, look, and I'll tell them this is objective, right? In the world of impairment ratings, you could tell me that, you're writhing on the ground in pain, but that doesn't count for impairment ratings. I'll explain to them because anybody could say it hurts.
Great. I don't have any other questions right now.
Return to work status. Somebody had asked before if I look at job evals in terms of what individuals are doing in terms of their work status, and it's yes, when it's available. I think it's important to know. So return to work status is always one of those things that I really need to look at, and I really try to look at as objectively as possible, because as we know, a lot of individuals and they're getting these IMEs. The ones that are coming to see me for causality are the ones that are coming to see me because they just haven't been back to work, right? They haven't followed the regular path that we would expect. Okay, so I've probably done 3,000 rotator cuff surgeries in my life in the past 21 years, and I can tell you exactly, just based on my experience, kind of where somebody should be at what point. So again, I saw somebody recently I did an IME on, and they were using one of these pounders as a landscaper, and this thing weighs like 100 pounds, and they kind of slipped and it went flying, and they had a rotator cuff tear. And I read through the report, and I saw the pictures and everything objectively, and it was a good surgeon. That's the other thing. Like I do these IMEs, and a lot of times I kind of know from the surgeons who is I don't know. I don't like to say good or bad. Okay, experienced. Who might be more experienced with treating a certain condition than others, and who might have more reproducible results. So this individual had a very good, reputable surgeon. Pictures look great, and everything looked on the up and up, right? So, and he was now 7 months out from his rotator cuff surgery. And somebody who had seen him, I looked at the workers' comp form, and he had like a 5-pound max, lift, which doesn't make any sense to me. So when I looked at this individual and I objectively evaluated him at the IME, he didn't have any atrophy. He had smooth motion, passively shoulder. When I kind of distracted him, his strength was his strength for manual testing was fine. So I'm looking at him, and again, so he was sent to me because somebody somewhere, somehow, after 7 months, gave him a 5-pound weight restriction. And as the treating physician, I've been in that position, and it's hard because you have an individual who keeps coming in, right? He comes into the office, he goes, I can't go back to work. He goes, my shoulder hurts. I can only lift 5 pounds. I can only lift 5 pounds. And he keeps on saying this, right? And as the clinician, we've all been there. It's a very tricky situation because you can't so you could only try to advance him as far along as you can. And again, the reason why they send these individuals for IMEs is to kind of take the clinician, like me, when I'm the clinician, to take you out of the picture and to have somebody look at it independently. So this guy, I looked at the whole thing, and they asked me, what is his return to work status? And kind of objectively looking at him, I'm like, well, no, he could work, and I had his job description, right? So he had to lift 50 pounds, and he had to drive a truck. He had to push and pull. And I looked at all of that, and I basically filled out in the IME, individual can lift 50 pounds, can push and pull this, can do this, based on review of job description and what he can do, he could return to work full duty. So here I am, I'm returning him back to work full duty with my IME. His treating physician gave him a 5-pound, work restriction. And again, sometimes it's tough as the treating physician because you have that doctor-patient relationship, right? And you really are there to be your patient's advocate, even if they're not really on the up and up. It's very difficult. And this is how I feel as a treating physician. It's very difficult to kind of push them along sometimes. You can. So then what do we do, right? We get an FCE, right? Because our hands are tied. We're trying to get him back. 5 pounds, 10 pounds. So he goes back. So he goes back to work, 10-pound restriction. Then he comes back. I couldn't do it, doc. They were really torturing me at work, and they're not following the restrictions. So then you send in somebody for a job site evaluation to see if that's the case. You do an FCE, and with an FCE, supposedly there's some inside controls when you do it to be certain that people are on the up and up. But in the end, I understand it's the return to work status. This is you guys as case managers, you see it every day. And we know that there's no right answer, right? We know that we're just trying to get as much information together, right? So you get your IME, you have your FCE, you have your job site evaluation, you got to look at the whole thing, and then that's what you got. And then sometimes you say permanent restrictions, and sometimes you try to just get them back to work and see what happens. We've all been there. We know what happens. But return to work status, again, is a very common reason that I see individuals for IMEs. Any questions?
Talk about work conditioning as part of the
Yeah, so I think that's a good point. I think work conditioning is great. I think that work conditioning is very dependent upon where you send them for work conditioning. And I can tell you that I've had, there's one place that we use work conditioning that we love. So there's also somebody, it's a guy, somebody down in Hampstead area, I forget. You know what I'm talking? Well, there's a few people, I don't know off the top of my head, who are excellent. I'll give you an example. Sorry. No, our phone rang, sorry. So as a clinician, I'll give you an example. I've had 2 individuals specifically who work for Eversource, They work up in the bucket, right? So these are like individuals that if their shoulder's like not 100%, like they can die, right? When they're reaching out of the bucket and they're working with high voltage. So I've had two individuals specifically that come to mind immediately that I sent them to work conditioning for 4-6 weeks afterwards, and they were able to get back to their job. So for those of you that don't know what work conditioning is, I explain it is that basically it's a trial run for your job. So if you work for UPS, work conditioning will have you lifting boxes and carrying them. If you work for Eversource, they might have you doing, holding, they use this instrument in which they work in the power lines in which their arm is really out extended. So if the work conditioning would do some apparatus like that. So yes, I think work conditioning, absolutely. But again, there's a few places that are probably better than others in my clinical experience in terms of where to send individuals.
So are there therapists that specialize in work conditioning, or would any therapist be able to do a work conditioning program?
I would say that there are specific therapists that have work conditioning programs. Mm-hmm. There are other therapy places that kind of do it. Like there's some therapy places that would actually come out and say, look, we have a work conditioning program, and they're very experienced at it. There's other therapy places that say, okay, well, we'll do some work conditioning for you, but it's not really the same. I can't tell you, again, so what happens, this is how it works. So if I have an individual that needs work conditioning, I'll basically ask Phyllis, hey, Phyllis, you know what? I know there's 3 or 4 places that we really like. Remind me again, and that's what we'll do.
Okay, thank you. I don't have any other questions right now.
I think that's it. So if there's any other questions about anything that we've spoken about, any topics, please feel free to ask.
So now's your chance, everyone. If you want to type a question into the Q&A box at the bottom of your screen, we're happy to ask Dr. Gumas the question. We'll wait a few seconds for that, see if anything pops up. Let's see, I had maybe another question or two for you. Worksite evals. Did you talk about worksite evals and actually explain that?
Yeah, so in my experience, most worksite evaluations are done by I don't know, many of you know Sue Emerson, occupational therapist, and she goes out, worksite, and looks really specifically at every single component of what the individual is, what their day is like. So recently I saw a worksite evaluation on an individual that worked at Harvey Industries. Okay. So at one point of the job, she was riveting. At another point of the job, she was putting glass in a frame. Another point of the job, she was doing something else. And the worksite evaluation will look at how many cycles, we'll look at first the work site, right? How high is the table? How high is the bench? How many cycles of this repetitive activity is the individual doing? So worksite evaluations can be good in some cases. Let's say that you don't know somebody. So again, recently a case that came up, woman complains of wrist pain, carpal tunnel syndrome. The question is it as a result of her job? So there was a worksite evaluation that kind of looked at what she was doing. There's been lots in the literature that discusses the environmental hazards in terms of developing carpal tunnel syndrome. So you look at the worksite evaluation. So okay, when you look at all this, does it make sense that this would cause carpal tunnel? Okay, so that's one use of a worksite evaluation. The other use of a worksite evaluation is getting somebody back to work, right? So is so-and-so able to go into, I just did shoulder surgery on Mr. Smith, and he's now 4 months out. He's not quite ready for full duty yet. We're going to look at what they're asking for him to do. And there could be a worksite evaluation to see, how much is he lifting? How high is the bench? And how high is the case in which he's putting things away? So Worksite evaluation is also very helpful for that. We do worksite evaluations. Again, when it comes down to we all know, right, as case managers and doctors, we all know, like, getting the person back to work sometimes is the biggest challenge. I think it probably is the #1 biggest challenge. So how do we do that, right? We do that with an objective exam, sometimes with an FCE, with a worksite evaluation, all the kind of stuff. We put it together and we try to get them back. So yes, worksite evaluations are important.
And then just one other thing that popped into my head, is there any standard, does any organization set standards for work conditioning programs, or is there any accreditation for a work conditioning program or anything like that? That you know, they would be like a preferred provider for an insurance network, or?
No, the answer is I don't believe that there is.
Okay.
When we do work hardening, about 4 hours. So about 4 hours. So I'm talking to Karen here. So when we do work hardening, you know, it's like their job, right? I mean, so we want it to be kind of like their job. So 4 hours a day, 5 days a week. I know that Apple therapy, I know that copula therapy, and then there's a place that I really like to use as well down in Windham. Doesn't come to mind, but to your question as to whether or not there's a governing body, the answer is not that I know of.
Okay, thank you. I don't have any other questions. I want to thank you, Dr. Gumas. This has been a really informative program. I want to thank our